Hello, this is Dr. Joe Bart, Operational Medical Director for UBMD EMS, here to talk to you today about COVID-19 vaccination. What is the vaccine and is it safe? A few goals I want to talk about today is, what is the vaccination? How was the vaccine created? Is it effective? How was it tested? Expectations of receiving the vaccine in New York State, some potential side effects, and how is safety being monitored? So how is the vaccine being made? The messenger RNA technology for vaccinations is not brand new and has proven effective. It is a decade-old process used currently with cancer vaccinations. It is most beneficial for this type of development as you do not need to create large amounts of the antigen, just copies of the RNA code. This also allows limited ingredients as well. It is also not a live virus like some vaccines. There is no preservative because it is a messenger RNA code. The lipid nanoparticle is a vehicle to allow it into the cell, otherwise it would just float around the bloodstream. The messenger RNA does not enter the nucleus and cannot manipulate or change the nucleus or the brain of the body cell. Messenger RNA vaccines provide instruction to the immune system. The spike protein encodes, in a natural context, a natural body response with B cell and CD8 and CD4 immunity. Okay, let's use plain language. Do you remember the COVID-19 virus picture? Yeah, that one. The little red guys are called spike proteins. Those are what sticks to the body cells and eventually gets the virus into the cell. The vaccine made a replica of the spike protein to present it to the cell. The cell sees it as an intruder and starts to build an immune response to it. Even though the virus is not attached to the spike protein, the body will see it, respond, and remember it, kind of like a fingerprint for COVID-19. If the body were to ever see it again, the antibodies are released like stormtroopers. They will attack the COVID-19 virus and put a cap over the spike protein before it can enter the cell to replicate. Antibodies are like the 911 response to a viral intruder. The messenger RNA and lipid molecules are the only ingredients. The messenger RNA is not processed within the nucleus of the body cell and cannot manipulate the cell. The B cell reaction is what is producing antibodies. Think of it like a quick reaction response team. The antibody is not directly part of the vaccine, but rather the code of the COVID-19 spike protein. As it is presented to the body cell, each person's body will then form antibodies similar to if you were actually exposed to COVID-19, but without the virus actually inside your body. This is why some mild systemic reactions are expected and considered a positive thing, as an expectation that the immunity is building. The reaction by the CD4 and CD8 T cells is what builds memory to COVID-19 in case the body is presented with the infection in the future. It will remember COVID-19 and start to defend against it. The T cells are called cell immunity. Think of these fellows like a high school hall monitor with a really long memory. Vaccine effectiveness. Moderna and Pfizer both state that the effectiveness of their immunization is greater than 90%. The effectiveness was tested across all of FDA-required age, racial, and ethnic groups. To say there was pressure to make a vaccine is accurate, but that should only be in the context of our desires to limit additional restrictions, bad side effects, and simply move on. The FDA is not in the business of cutting corners, and if the vaccine being developed could not hit the metrics of effectiveness and thresholds of safety, there was no outside pressure that would have cleared them. This is important to understand, as the cornerstones of modern medical safety is tantamount to these processes, and the medical community at large needs to stand behind them. The rapid process that was used sounds like they cut out steps, when in fact, they added several new processes to watch the vaccine in real time. The rapid part was the clinical trial. Generally, a new medication or vaccine will have had several years, so they have time to enroll all of the required patients. The participation of the entire country to enroll greater than 30,000 patients and track them was an enormous undertaking, but with the cooperation of many partners was accomplished in a little less than a year. The promotion of the vaccine and its safety, especially compared to COVID infection data, is part of being a healthcare provider. Some individuals have less risks and feel they won't need a vaccine. That is different than a healthcare professional saying it is unsafe and they don't trust its effectiveness. As healthcare professionals, we must be mindful of the message we carry. As stated, there were over 30,000 people in the phase 2-3 clinical trials just for the Pfizer vaccine. Specific group testing for immunocompromised, treated or untreated HIV have not been concluded. Vaccination is still recommended for this group due to the higher risk of COVID infection than presumed vaccination side effects. DART studies are specific to pregnancy. This is the type of data that helps determine risk during first, second, and third trimesters. The studies have also not concluded on this data yet, but the suggestion is that pregnant females should discuss the vaccine with their own doctors. Mild allergic reactions should not be a contraindication. There were 2 individuals in the UK that were reported to have had serious allergic reactions. It was not reported widely that those 2 patients have also had severe allergic reactions to medications and vaccines in their past. Post-vaccination side effects most common were fever, fatigue, headache, pain at the injection sites, and body aches, but were all considered mild, and most will resolve within 1 to 2 days. Mild side effects were more commonly reported after the second dose and were more frequent in ages 18 to 55 and less frequent in ages greater than 55. Local or systemic reactions were again the most common side effects, where the recommendation was treatment with acetaminophen. Should these signs or symptoms develop during a period of time where vaccination was delivered and immunity is building, generally within the first few weeks, testing for COVID-19 should still be considered. Other infectious diseases are still possibilities, and an evaluation by a healthcare professional should be considered. Expectations of receiving the vaccine. New York State will be receiving vaccinations from Pfizer and Moderna as per previously contracted. Those will be allocated then to hospital systems who are already distributing vaccinations to high-risk personnel. EMS is considered Phase 1A per New York State Department of Health and the CDC. Per this diagram, we can see the population risk and the essential worker phases. The vaccination strategy is divided into 5 phases. At the very top is healthcare workers, both clinical and non-clinical, inpatient care settings, which would include ICU, emergency department, and EMS as the top priority. Just last week, we started to enter into Phase 1, and EMS is the next priority group. You will soon be contacted to receive the vaccine. As part of your job category, the Department of Health will authorize vaccination as discussed on the previous slides. The only major contraindications are severe allergic reaction to an ingredient of the vaccine. Each vaccination facility will be prepared for severe allergic reactions and will monitor for 15 minutes after the vaccination. There is no existing link to vaccine type or shellfish allergy. There are no vaccine allergies or specific medication warnings. There are also no precautions on this vaccine related to allergies for foods, pets, pollens, latex, or shellfish. Patients with underlying conditions, even autoimmune, if recommended for vaccination, should receive it. The safety data still needs to be studied, but they should be offered the vaccine. Cytokine surge did not occur in immunosuppressed patients and has not been seen much in the actual disease. Immune response to vaccination is not causing this type of immune response, but may be localized to skin, muscle, or local lymph as the vaccine does not get into the body systems. There is no shortage on stories of bad outcomes. While each person has to look at their own risks, we should also be mindful of our job risk of exposure and potential for transmission to those who have increased morbidities. The research put into this so far outweighs any risk of mild reaction. All that said, the COVID-19 vaccination is voluntary. As of the time of this presentation, there is no repercussion for not receiving a vaccination as an EMS provider, although it will be encouraged for all providers. If you choose to be vaccinated, most commonly you will have pain at the injection site, and the most common side effects again are mild fever, fatigue, headache, pain at the injection site, body aches, but were all considered mild side effects expected to resolve within 1 to 2 days. You should be committed and prepared to receive both recommended doses. The second dose is 14 days later and should provide an immunity of greater than 95%. No vaccine, however, is 100%. For now, there is no free pass after being vaccinated, and you are unlikely to see any restrictions recalled on workplace safety like masking and distancing. Post-vaccination, all patients are required to have the frequently asked questions sheet either printed or electronically. You will also receive a shot card and record to immunization in the registry. CDC wishes to monitor vaccine safety by having all patients send in any and all side effects. I'll get to that in a few slides. Written informed consent is not required for emergency use authorization, but it is a requirement to provide the fact sheets to each patient. CDC recommends documentation of vaccine administrations only. This is something new for the CDC. The CDC vSafe platform or application, this is a new platform to be monitored by the CDC for long-term side effects and any type of medical events. All events that are clinical will be recorded and reported. vSafe is a smartphone-based technology for vaccination program in which anyone that has had the vaccination can report any and all potential symptoms. The CDC may use that information to directly check in with each patient. They conduct daily electronic check-ins during the first week and then weekly for several months. The timeline will reset after your second dose. This app requires self-registration using your own smartphone. This is voluntary, but it will help you and the CDC track any potential side effects. Worldwide surveillance and reporting is helping everyone to detect rare and adverse side effects. So your expectations after vaccination. Vaccination will not trigger antigen-specific testing, and any positive test should be presumed infectious with symptoms for a period of time between vaccination and established immunity of 1 to 2 weeks. So in the meantime, testing should be conducted with new COVID symptoms. So with the vaccination and the potential for side effects related to the vaccination, there should be some discussion on the concern of post-vaccination symptoms versus infection symptoms and how we might mitigate those. Concern is that post-vaccination symptoms may be considered infectious and exclude personnel from work. But a strategy needs to also identify infectious symptoms to avoid continued spread. A few things we can do, like staggering delivery of vaccinations to not potentially wipe out an entire department, company, or platoon. Ideally, providing vaccination on the second day of a tour to which vaccinated healthcare providers would not be expected to return to work for 1 to 2 days. There's also the importance of letting vaccine recipients know what to expect. SARS-CoV-2 testing needs to remain readily available in case that non-vaccine related symptoms are being monitored and begin to develop. All symptoms are encouraged to be reported, and again, anyone receiving vaccination is required to also receive written or electronic frequently asked questions and reporting information at the time of their vaccination. A couple of frequently asked questions that have come up, also from the survey that was put out. If I had COVID, should I get a vaccine? People that have had COVID are recommended to be vaccinated, whether they were symptomatic or asymptomatic in their initial positive test. Those who were recently infected in the past 90 days could defer their vaccination as it is presumed they have antibodies. Current infections or recently recovered infections should also defer their vaccination. I have asthma, and I'm concerned on the specific recommendations for this condition and testing related to this. The triggers for asthma are acute inflammatory reactions. there is no connection to the vaccine triggering inflammatory markers specifically related to asthma diagnosis. The reactivity of respiratory conditions likely is more problematic with COVID infection, and this should be considered when determining risk factors and benefits of vaccination. RNA vaccines have not been studied. The synthetic messenger RNA vaccination is really not new. It's rather genius to use the body's natural antibody-creating systems to direct protein production in cells throughout the body in order to make antibodies. The messenger RNA does not enter the nucleus of the cell, but rather triggers the cell to recognize the COVID-19 antigen and form antibodies in memory against it. There are dozens of worldwide trials using this technology for autoimmune conditions and cancers. The vaccine was rushed, and that concerns me. I get it. It sounds bad. Operation Warp Speed, as declared by the Trump administration, could be perceived as a process to bend corners and remove testing barriers. It's not the case, though. With the removal of barriers, it allowed research to continue, and in this case got immediate, not less, attention from the review authorities. All the risk taken is financial, logistical, and resourcing, but not on the safety or efficacy. History provides us details in vaccination. The swine flu and H1N1, in which vaccination strategy and inability to create a vaccine in a timely fashion were the major criticisms. The need for public protection is not vastly different from 1976 to 2009 to 2020. Recent polls showed declining confidence in the rapid release of a COVID-19 vaccine. In one poll, only 13% of respondents said they would want to get a vaccine immediately when it becomes available. Another 16% said they would get it in a few weeks. As with the 1976 swine flu vaccine, unexpected adverse events seem to be linked to those opinions. While those long-term side effects cannot be predicted today, don't let the perception of the vaccine development and dissemination be the reason why you would question its effectiveness and availability. I get the flu vaccine every year, and I still get the flu. The only thing in common here is the word vaccine. The flu vaccine is not the COVID-19 vaccine. They are different in structure and design. The COVID-19 vaccine is effective for SARS-CoV-2 virus, which has so far not changed. This is similar to other vaccines you have received, and they may remain effective because disease communication is low. The flu vaccine is a best guess of likely strains of influenza for the given year. You may still get symptoms of the flu, but the vaccine you would receive likely help your immune system to recognize the family of virus and fight it off with few or less severe symptoms. If we fear COVID-19 becoming a new strain, then immunity can help that. Viruses replicate in the human body as a host, and if they cannot infect the human body because we are all immune, they are unlikely to change or create a new strain in the environment alone. Thanks for tuning in, be safe, and remember to wash your hands.